Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper. We're doing something different for the next 3 episodes. To help me prepare for an upcoming ATS course, I'm turning my study notes into a Masterclass synthesis for the PRISM community. We're focusing on lung protection, driving pressure, and mechanical power. This series is about the evolution of the science, moving from isolated trials to a cohesive strategy for the bedside.
Picture a patient lying in the ICU, let's just say in bed 4. Their eyes are closed.
Right.
The room is totally quiet, except for that rhythmic hiss of the ventilator.
Yeah, that familiar sound.
Exactly. You check the monitor, and heart rate is 85, saturations are 94%. You glance at the chart, and they're deeply sedated, like a -4 on the RSS scale.
Looking totally peaceful from the doorway.
They look completely asleep. But what you can't see is that underneath all that chemical sedation, their diaphragm is contracting so violently and so out of sync with the machine that it's literally shredding their lungs from the inside out.
It's terrifying when you actually think about it.
It really is. I mean, microscopic muscle fibers are tearing, alveoli are over-distending, just popping.
Yeah.
Inflammatory cytokines are basically flooding the bloodstream.
Yeah.
The patient looks asleep, but physiologically, they're basically running a marathon while breathing through a straw.
And their own respiratory drive is what's killing them.
Right. And that invisible trauma is exactly what we're tackling today. Welcome to PRISM Rounds.
Yes, welcome. And, for decades, the intensive care community just kind of operated under this assumption that, well, if the blood gas looks okay.
Yeah, and if they aren't physically fighting the restraints.
Exactly. We thought, the mechanical ventilation strategy was working. We viewed the vent as just a life support bridge.
Just a temporary fix, right?
Right. But the reality is that the ventilator is this active, highly dangerous pharmacological agent, essentially. And how the patient's brain and respiratory muscles interact with that machine, well, that dictates their survival way more than just the FiO2 we set on the dial.
So true. Think of this deep dive as like a highly specialized physiological masterclass. If you're an ICU trainee, a fellow, or really just any medical professional who wants to elevate your bedside practice, this is for you.
Absolutely. We're moving way beyond just turning dials to make the alarm stop.
Yeah, our core mission today is to completely deconstruct the old paradigm. I mean, we all grew up on lung protective ventilation, right? The ARDS-NET protocol.
Low tidal volumes, keeping plateau pressures under 30.
Exactly, the gold standard. But today, we're crossing into this completely new territory. Lung and diaphragm-protective ventilation, LDPV.
Because we have to protect the muscle just as fiercely as we protect the lung tissue itself.
Right. And to do that, we are synthesizing some of the most practice-changing research in respiratory physiology.
We'll be looking at the foundational work from Blanch on asynchrony, Vaporidi, and Sousa on lethal clustering.
Oh, that clustering data is wild.
It really is. Plus, Ewan Golliger's framework for diaphragm protection, Bertoni and DeVries on non-invasive mechanics. And we're really going to dissect this brand new 2025 breakthrough from LV and colleagues.
The real-time NT-MOT stuff.
Exactly. It's game-changing. We're not just giving you a list of vent settings today. We are drilling down into the actual molecular and mechanical biophysics.
Okay, let's unpack this. We have to start with the why. The concept of patient-ventilator asynchrony. Historically, if the vent was alarming because the patient was double triggering, how was that handled?
Oh, it was treated as just a total annoyance.
Right, like, oh, it's just a noisy patient.
Yeah. The nurse or the resident would walk in, maybe push 50 of fentanyl, hit the alarm silence button, and just walk away.
I've done it. We've all done it.
We all have. But we didn't realize it was actually a lethal problem until much later.
So when did that paradigm shift actually happen?
It was really in 2015.
Yeah.
Blanch and his team published a study that fundamentally changed how we look at the waveform screen. They didn't just take a snapshot of the patients.
They use continuous monitoring, right?
Yes. Dedicated software analyzing over 7,000 hours of mechanical ventilation data across multiple ICUs.
Which is what, like 8 million individual breaths?
More than 8 million. And what they discovered was that these asynchronies aren't rare at all. They're happening 24/7.
On every vent mode.
Exactly. Assist control, pressure support, SIMV, it didn't matter.
And what was that critical threshold they found? The AI?
The asynchrony index, yes. They found that if an AI is greater than 10%, meaning more than 10% of the patient's efforts are out of sync with the machine, clinical outcomes just completely fall off a cliff.
Wow. So an AI over 10% directly links to what exactly?
Higher ICU mortality, higher hospital mortality, and a way longer duration on the vent.
And the craziest part about the Blanch data to me is that this was happening in patients who looked perfectly fine.
Right. You might stand there for 60 seconds, look at the screen, see mostly machine-triggered breaths, and think, oh, they're synchronous.
But the software saw everything underneath.
Exactly. Massive asynchrony is totally missed by routine observation.
Okay, but I want to make a distinction here. Because an isolated event, like a patient coughs or hiccups and misses a trigger, that it isn't driving mortality, is it?
No. And that's where the newer research comes in. The real danger is the density of these events, the clusters.
Clusters.
Right.
Vaporidi's work in 2017 really highlighted this.
She did. She showed that the temporal distribution is what matters. She defined an ineffective effort cluster, an IE cluster, as more than 30 ineffective efforts in a tight 3-minute window.
30 times in 3 minutes. Just think about the mechanical density of that.
It's brutal. 30 times the brain sends a signal, the diaphragm contracts, and the ventilator just does nothing to help.
And then Sousa took that same concept in 2021 and looked at double triggering in the Epi-C cohort, right?
Yes. Sousa defined a double triggering cluster as 6 or more of these events in 3 minutes.
And the outcomes are just terrifying. If you spend a cumulative total of 12 hours or more in these dense clusters over your whole ICU stay,
Your 28-day survival just plummets. It's a massive independent spike in mortality.
So we have to ask the obvious physiological question here. Why? Why is a cluster of ineffective efforts so uniquely lethal to the diaphragm?
Well, let's break down the biophysics. When an ineffective effort happens, it's almost always during the ventilator's expiratory phase.
Okay, so the vent is trying to let the air out.
Right. The expiratory valve is open, the lung is deflating back to the set peat, but the patient's neural drive is totally out of sync.
So the phrenic nerve fires anyway.
Exactly. And the diaphragm fiercely contracts, trying to pull air in, while the machine and the lung's recoil are physically pushing air out.
Let's visualize this perfectly.
Yeah.
The diaphragm is this dome-shaped muscle. Normally it contracts, flattens, moves down, pulls air in.
Right.
But during this ineffective effort, the mechanical forces of the vent are basically pulling the muscle back up to the chest cavity, stretching it out.
Yes. You're describing an eccentric contraction.
Those are bad.
Very bad. In muscle physiology, you have concentric contractions where the muscle shortens and eccentric where it lengthens while trying to generate force.
Like trying to do a bicep curl, but someone is forcing your arm straight.
Exactly. Any sports medicine doctor will tell you eccentric contractions are what cause profound, immediate structural muscle damage.
The sheer stress just tears it apart.
Yep.
The internal architecture of the muscle cell gets sheared.
It's like my favorite analogy for this. Driving a manual car, going 50 miles an hour, and you violently try to shove the stick shift into first gear.
Oh, that's a perfect way to picture it.
Right. The engine wants to spin one way, the wheels force the transmission the other way. You're not just making a grinding noise, you are instantly shearing the metal teeth off the gears.
And every single ineffective effort in that cluster is the diaphragm just grinding its gears against the vent.
So on a microscopic level, what is actually happening to the muscle fibers?
Macroscopic grinding equals microscopic devastation. You get immediate sarcomere disruption. The Z-discs inside the fibers are physically pulled apart,
Wow.
which causes the sarcolemma, the cell membrane, to tear.
Mm.
And when that tears, extracellular calcium just floods into the cell.
And calcium triggers the inflammatory cascade.
Right. It triggers calpain activation, which starts this rapid protein degradation and local inflammation. You are essentially causing rhabdomyolysis of the diaphragm. Rhabdo of the diaphragm. That's a wild concept.
Yeah.
But okay, that perfectly explains the muscle injury. What about Sousa's data on double triggering and lung injury?
So double triggering is a form of severe breath stacking.
The patient starts a breath.
The vent delivers the set tidal volume, right? but the patient's brain wants to inhale for longer than the machine's set time.
So the machine tries to cycle off, but the patient is still pulling.
Exactly, which instantly triggers a second breath before they've exhaled the first one.
So the math there is devastating. You spend all morning calculating a nice, ultra-protective 6 cc's per kilogram tidal volume.
And boom, they double trigger, and suddenly they're getting 12, maybe 14 cc's per kilo in one massive inflation.
Which completely obliterates lung protective ventilation.
Totally. Delivering 14 cc's into an injured ARDS lung causes catastrophic alveolar overdistension.
The physical stretch just rips open the channels.
Yes, specifically the PISA1 and TRPV4 stretch-activated channels. When they rip open from tension, alveolar macrophages release a tsunami of inflammatory cytokines, interleukin-6, TNF-alpha.
So mechanical stretch trauma instantly becomes a systemic biological fire. Macro trauma causing microtrauma.
Exactly. And there's a really counterintuitive finding in Sousa's study that we have to talk about.
The sedation paradox.
Yes. We naturally assume that the patients awake and thrashing around are the ones getting these lethal clusters.
Because they look like they're fighting.
Right. But Sousa found these deadly clusters were actually more common in patients under deeper sedation during the first 2 days.
I always struggle with this clinically. The instinct is patient is fighting, double triggering, so push more propofol and fentanyl to suppress the drive.
Right, but how does deeper sedation actually cause more asynchrony? It's this complex paradoxical feedback loop.
Break that down for us.
When you deeply sedate them, you suppress the drive, yes, but you also alter their neural timing. Deep sedation prolongs their neural exhalation time and blunts their CO2 response.
So they get out of rhythm.
Yeah. And frequently, the vent delivers a mandatory breath to a passive patient, which stretches the lungs, stimulates vagal stretch receptors, and reflexively triggers the diaphragm to contract late.
So it's a reflex, not a conscious drive.
Exactly. It's called reverse triggering. The machine triggers the patient, not the other way around.
The brainstem is asleep, but the spinal reflexes are still firing, making the diaphragm spasm against the flow. That's wild.
Yes. Plus, deep sedation leads to shallower breaths that don't empty the lungs, which causes auto-PEEP.
Air trapping.
Right. So alveolar pressure is positive at the end of exhalation. To trigger the next breath, the diaphragm has to generate enough negative force to overcome that trapped positive pressure first.
Before the vent even senses they're trying to breathe.
Exactly. If the muscle is weak from sedation, they try to breathe, fail to overcome the auto-PEEP, the vent ignores them, and bam, ineffective effort.
Okay, so heavy sedation makes it worse, and clusters cause massive rhabdoid inflammation. What are we supposed to do? Is the bedside nurse supposed to just stare at the flow waveform for 12 hours straight?
Doing hash marks on a notepad? No.
Right, because logistically, in a busy ICU, that's impossible.
Completely impossible, and it's the wrong approach anyway. You can't retroactively manage asynchrony.
Because by the time you see the cluster, the damage is done.
The sarcomeres are torn, the cytokines are released. We have to be proactive. We have to set the vent and manage sedation to keep their underlying effort in a safe range from hour 1.
If you control the drive, you prevent the asynchronies.
Exactly. And this is the foundation of the Goldilocks Zone.
Let's transition right into that framework.
Yeah.
Because the Goldilocks Zone is really the beating heart of LDPV. Ewan Gollier and DeHero's group really championed this in 2019 and 2020.
They did. They argued that completely resting the lungs is fundamentally flawed. We have to let them breathe, but strictly bound that effort.
So what are the actual numbers? What is the sweet spot?
The target parameter is inspiratory muscle pressure, or PMUS, the total pressure from the diaphragm and accessory muscles.
And the physiological sweet spot is what, 5 to 10?
Yes, 5 to 10 centimeters of water. If you have an esophageal balloon in, that correlates to an esophageal pressure swing, or delta PES, of -3 to -8.
That's the ideal work for the diaphragm. But we have a dual mandate here, right?
Right. We want the diaphragm working at 5 to 10, but we have to make sure the lungs aren't overstretched.
So what's the second parameter?
Dynamic transpulmonary driving pressure, or delta PL. This is the actual physical stress distending the alveoli. This has to be kept less than or equal to 15 to 20 centimeters of water.
So moderate muscle pressure, low transpulmonary stress.
That is successful LDPV.
Let's explore what happens when we miss that zone, because the literature describes this as a U-shaped curve of injury.
Yes, the U-shaped curve.
Let's start on the left side. Over-assistance. We paralyze them, or the pressure support is too high. Zero effort.
When a skeletal muscle goes completely silent in the ICU, the deterioration is terrifyingly rapid. We're talking ventilator-induced diaphragm dysfunction, or VIDD.
How fast does that happen?
Within 18 to 48 hours of total inactivity, profound disuse atrophy. And it's not just weakening. The molecular breakdown goes into overdrive.
The ubiquitin-proteasome system.
Yes, and autophagy pathways. The muscle fibers literally digest their own contractile proteins to save energy.
I always conceptualize the diaphragm as an elite high-performance endurance athlete. It's been contracting continuously since birth, full of type I slow-twitch fibers.
Right.
If you take a marathon runner, put them in a full-body cast in a coma for 3 days, their leg muscles melt away. When they wake up, they can't stand.
And that's what happens to the diaphragm. We try to extubate, and it collapses under the load.
Exactly.
The cross-sectional area of those type I fibers shrinks by 20 to 30% in just a few days. And there's a huge clinical misconception here.
Oh, about pressure support.
Yes. People think if a patient is on pressure support and triggering the breath-generating maybe -1 or 2 centimeters of water to tell the vent to deliver air, that's enough to prevent atrophy.
But it's totally not.
It absolutely is not. Triggering a sensitive vent requires trivial work. It doesn't provide the mechanical tension needed to maintain protein synthesis.
To stop the ubiquitin-proteasome system, they need to generate real tension.
That 5 to 10 centimeters of water, they need to lift some weight.
Okay, so over-resistance melts the muscle. Let's swing to the far right side of the U-curve, under-resistance.
The vent isn't helping enough, or they have severe metabolic acidosis driving massive breaths.
Right, pulling a PEMAS of 20 or 30. Using the athlete analogy, this isn't the body cast. This is forcing an injured runner with pneumonia to sprint an ultramarathon.
And the diaphragm will experience structural failure. Plus, Tonelli's 2025 paper highlights a hemodynamic consequence here that everyone overlooks.
The metabolic cost of breathing.
Exactly. Normally, breathing takes maybe 2 to 5% of your cardiac output. Highly efficient.
But in a shock state, with severe ARDS.
It surges astronomically. The struggling diaphragm can steal up to 50% of total systemic oxygen delivery.
50%.
Yes. The diaphragm becomes a metabolic black hole. If your patient is in septic shock, hypotensive, fighting the vent, the diaphragm is robbing oxygenated blood from the brain, the kidneys, the splanchnic bed.
So you're pushing vasopressors to save the kidneys.
But the diaphragm is hoarding the blood, so the kidneys fail anyway from ischemia.
That is an incredible way to look at it. The respiratory muscles outcompeting vital organs for survival. And beyond that, there's the mechanical trauma. Patient self-inflicted lung injury, PSILI.
PSILI is driven by extreme fluctuations in pleural pressure. When they take a massive breath, the diaphragm contracts violently downward, creating profoundly negative pleural pressure, sometimes -30 centimeters of water.
A massive vacuum inside the chest. And what does a vacuum do? It pulls fluid.
Precisely. It vastly increases the transmural pressure gradient across the pulmonary capillaries. You are literally vacuuming plasma out of the capillaries and flooding it into the alveoli,
Causing rapid onset hydrostatic pulmonary edema.
which severely worsens the oxygenation you're trying to fix in the first place.
And then there is a cult pendulift. I remember first learning about this. It sounded like a physiological magic trick.
It really does, but it's a deadly mechanism. To understand pendulift, you have to visualize the ARDS lung not as one balloon, but millions of heterogeneous elastic units.
Right. The dependent areas, the back and bottom, are stiff and heavy with edema.
And the non-dependent areas, the top and front, are relatively healthy and compliant.
So a spongy, healthy area right next to a stiff, collapsed area.
Exactly. When the diaphragm forcefully contracts, that negative pressure doesn't distribute evenly. It's strongest at the bases, right where the muscle pulls.
So that local vacuum causes gas to shift internally.
Yes. Air gets sucked out of the healthy, non-dependent alveoli and rushes downward into the dependent, injured alveoli.
And here's the magic trick part. This happens almost instantly, entirely before the ventilator has even pushed the main tidal volume down the tube.
That's why it's occult, or hidden. The ventilator screen might show a perfectly safe 400 milliliter tidal volume.
You think you're doing a great job protecting the lung.
But internally, that pendulift shift is causing local dependent alveoli to rapidly inflate as if they were getting 1,000 milliliters. Catastrophic localized stretch.
Shredded by their own effort. Wow. That summarizes the U-shaped curve perfectly. Too little effort causes VADD. Too much effort causes metabolic steal, pulmonary edema, and PSILI via pendulift. We have to keep them in the Goldilocks zone.
We must.
But here's where theory collides violently with clinical reality. Everything you just described relies on measuring PEMAS and transpulmonary pressure. Historically, you need an esophageal balloon for that.
Down the nose, into the esophagus, measuring pressure swings against the heart and lungs. And the adoption of that outside of academic centers is, well, it's abysmally low.
Virtually non-existent in community ICUs. It takes specialized gear, training, frequent recalibration. At 2 a.m. when the patient is crashing, you aren't threading a balloon.
No, you're not.
So we have to use the vent screen to find clues. How do we estimate these forces non-invasively?
This is where the last 5 years of research have given us an incredible toolkit. We don't need the balloon to get a highly accurate estimate. We have 4 specific maneuvers. P is 0.1, delta POC, the pressure muscle index, or PMI, and the continuous NPMIS monitoring.
Let's start with P0.1, evaluating the neurological signal. The airway occlusion pressure at 100 milliseconds.
Yeah.
How does this capture the brain's intent?
Tonelli and DeVries really popularized this. It relies on the speed of human reflex. The patient starts a breath, the brainstem sends a signal down the phrenic nerve.
Okay.
To measure the strength of that signal, the vent applies a totally unannounced transient occlusion. The inspiratory valve snaps shut for exactly 100 milliseconds, 1/10 of a second.
So they try to inhale, but the door is locked.
Yes, and because 1/10 of a second is faster than the brain can process a blocked airway and change its pattern, the patient continues to pull with the exact force commanded by their initial neural drive.
The vent just measures how much negative pressure they generate against that closed valve.
Exactly. It's a raw, unfiltered snapshot of the brainstem's command center.
If they're comfortable, the drop is minimal. If the brain is screaming for oxygen, they pull violently and the drop is steep.
Right. And our target P.1 to stay in the Goldilocks zone is roughly 1.5 to 3.5 centimeters of water.
Less than 1 means they're over-assisted, risking atrophy.
And greater than 3.5 or 4 means the drive is excessive, risking P-Sili.
I have to interject, though, because there's a huge technological caveat that Tonelli warns about. Not all ventilators actually do a physical occlusion for this, right?
Yes. Some manufacturers try to be clever. They just mathematically extrapolate the P.1 by looking at the normal pressure drop during the trigger phase of a regular breath.
And if they have auto-PEEP, that extrapolation is wildly inaccurate.
Completely. Think about auto-PEEP. Positive alveolar pressure of, say, +5 at the end of exhalation. To start a breath, the diaphragm has to pull that +5 down to 0 and then pull slightly negative just to trigger the flow sensor.
So they're generating 5 centimeters of invisible effort before the vent even knows they're breathing.
Exactly. If the vent just extrapolates from the visible pressure drop at the airway, it completely misses that massive initial exertion. The P0.1 reads falsely low. The machine tells you they're safe, but they're actually exhausting themselves.
Which is why we have to cross-reference P0.1 with our next tool, delta POC, the occluded inspiratory airway pressure. Bertoni's group brought this up in 2019. If P.1 is a snapshot, this is the feature film. How do we do this at the bedside?
It's remarkably simple. You stand at the vent, locate the expiratory hold button, wait until they reach the very end of exhalation, and then press and hold it.
Closing both valves, airway sealed.
Right. You keep it closed for a single, full, spontaneous effort. The patient realizes they're blocked and takes a maximum effort breath against the tube.
And because it's sealed, 0 airflow.
And according to the equation of motion, when flow is 0, resistive pressure is 0. So any change in airway pressure perfectly mirrors the change in overall pleural pressure. You just look at the screen and find the max negative deflection.
That total swing is your delta POC. And Bertoni showed this is a reliable surrogate for PMIS, but the real magic is calculating dynamic transpulmonary lung stress without a balloon.
The math here is elegant. You look at a normal breath. Peak airway pressure minus PEEP gives you the basic driving pressure of the machine. But to account for the patient's effort, you subtract a specific fraction of that occluded swing. Specifically, 0.67 times the delta POC.
Let me repeat that formula so it sinks in. Dynamic lung stress equals peak airway pressure minus PP minus 0.67 times delta POC. I want to drill into that 0.67 multiplier because otherwise it sounds like arbitrary academic sorcery. Why 2/3?
It represents the chest wall's stiffness tax. When the diaphragm contracts, not all that pressure goes into stretching the lung. A portion is spent physically deforming the rib cage and abdomen. In an average ICU patient, the ratio dictates that about 2/3 of the pleural pressure swing is transmitted to the lung parenchyma, and the other third moves the chest wall.
So we subtract the 0.67 portion because that's the fraction of their effort that is actively adding distending force to the alveoli.
Exactly. It isolates the specific stress applied to the lung. And the validation is outstanding. De Vries published a study in 2023 comparing this to a balloon. The AUROC was 0.90 for detecting dangerously high lung stress.
An AUROC of 0.90 for a completely non-invasive calculation that takes 5 seconds. Amazing. Okay, what about PMI, the pressure muscle index from Foti in 1997?
While delta-POC uses an end expiratory hold, PMI uses an end inspiratory hold. It's for patients breathing spontaneously on pressure support. They take a breath, the vent delivers pressure, and right at peak volume, you hit the inspiratory hold button.
Airway pressure instantly drops to a plateau pressure.
Right. The PMI is that plateau pressure minus the total pressure provided by the vent, so PEEP plus pressure support. The resulting number represents the elastic work their muscles are doing to hold that volume of air inside the expanded chest.
Overcoming the elastic recoil. And the safety threshold is 6 centimeters of water. Greater than 6 means their muscles are taking on an unsafe workload.
It's valuable, but it has a huge limitation. It only measures elastic work because it's static. It completely ignores resistive work.
Oh, pulling air through narrow airways.
Right. If they have bronchospasm, asthma, or a gunked-up ET tube, PMI severely underestimates their true effort.
Which highlights the big problem with all three of these tools.
Yeah.
P.1, delta-POC, PMI, they all require you standing there pushing buttons manually. Discontinuous data.
Highly episodic.
You check it at 8 a.m., looks great. 9 a.m., they spike a fever, drive skyrockets, and they rip their lungs apart for 4 hours while you're rounding.
We need continuous visibility. We need the vent to do the math breath by breath. And that brings us to LV's 2025 breakthrough on real-time NPFS. This transforms LDPV from a research concept into standard care.
I want to spend some time on this LV paper. It's a non-invasive algorithm running continuously in the vent software. But historically, bioengineers said this was mathematically impossible. Why?
It comes down to the respiratory equation of motion. The total pressure vent plus muscle equals elastic pressure plus resistive pressure. The problem is, during spontaneous breathing, you have too many unknowns.
Lung elastance, airway resistance, and the patient's muscle pressure.
Right. An underdetermined system. One equation, 3 constantly changing unknowns. Historically, algorithms tried to solve it by assuming expiration was entirely passive.
Assuming once they stop inhaling, muscles relax and the chest just recoils.
Exactly. If you assume that, you can use the expiratory flow curve to calculate resistance and elastance, then plug those into the inspiratory phase to solve for PMSS.
But that's clinically flawed. Anyone who's seen a severe ARDS or COPD patient knows they don't exhale passively. They use their abs to squeeze the air out.
Yes, active exhalation. And if they do that, the passive assumption algorithms fail completely. The resistance and elastance numbers become wildly inaccurate. This is the genius of the LV algorithm. They totally abandon the passive assumption.
They use a cubic function template, right?
Yes, a parameterized cubic spline function. It allows for continuous, smooth transitions between inspiratory and active expiratory effort. By mathematically modeling the likely shape of the active expiration, they added new constraints.
They turned an impossible underdetermined equation into an overdetermined one.
Precisely, using iterative least squares optimization to constantly refine the estimates breath by breath.
It sounds like abstract math, but the validation data is staggering. They hooked vents up to an active servo lung simulator with 270 complex scenarios. Active expiration, severe auto PEEP.
And the NPMS showed a 20/199 correlation with the actual physical effort of the simulator.
And the 2025 clinical trial in humans against esophageal balloons.
Correlation of 0.97. The bias was practically 0.
This means we're approaching a future where balloons are totally obsolete. NPMS will be a number on the screen next to oxygen saturation. Alarm! PMS exceeds 15.
It's transformative, but, diagnosing the problem is only half the battle. You see, the delta-POC, or NPMS, is reading 30, generating massive P-celli. How do you fix it safely without just paralyzing them immediately?
Right, which brings us to the how. The 2022 physiological trial by Jose Dianti and the Toronto team. They built a practical, step-by-step titration protocol to wrestle these patients back into the Goldilocks zone.
Yes. Step 1 is conceptually the hardest. Initiate spontaneous breathing as early as possible.
Which means pulling back the continuous sedatives and the vent rate to force them to trigger breaths. But waking up a patient with severe respiratory failure induces panic.
Severe physiological distress. You peel back the propofol, the brainstem senses the stiff lungs, and the drive skyrockets. They pull massive volumes. P.1 jumps to 6. They're visibly struggling.
And our instinct is to push more sedation and turn the rate back up.
But the protocol says hold your ground, don't paralyze them yet. Immediately move to step 2, titrate the PEEP.
This is a massive pivot. We're conditioned to view PEEP just for oxygenation. If SpO2 drops, turn up the PEEP. But here, PEEP is a mechanical tool to unload the diaphragm.
Exactly. Optimizing PEEP for dynamic lung compliance, or CL then, finding out how easily the lung stretches.
By testing different levels, like going from 8 to 10 to 14, how does better compliance quiet the drive?
Think about blowing up a stiff rubber balloon versus a soft party balloon. The stiff one takes immense force. If the ARDS lung is stiff from atelectasis, the diaphragm has to violently contract. By increasing PEEP, you splint open those collapse-dependent regions,
Pushing the lung onto the steepest, most compliant part of the pressure-volume curve.
making it physically easier to inflate. So the diaphragm doesn't have to work nearly as hard to get the same volume. You're taking the load off the muscle. Plus, you obliterate the mechanism of occult pendolift because the bottom is already open and stabilized.
And the Dianti trial proved that just finding the PEEP that maximizes compliance makes a patient 33 times more likely to hit their LDPV targets. 33 times.
It's our most powerful non-pharmacological tool. But what if you optimize PEEP and the brain is still commanding excessive effort?
Step 3. Systematically titrate sedation and inspiratory pressure, but to objective effort, not observational scales.
Right. This directly challenges the RAS score. The Richmond Agitation Sedation Scale is totally subjective. Are they thrashing? Are their eyes open? You push midazolam, they close their eyes. RAS -4.
But inside, as we discussed with the sedation paradox, they might be silently pulling negative 20 centimeters of water.
Exactly. RAS gives a false sense of security while they shred their lungs. Dianti removes the guesswork. You titrate propofol or fentanyl while continuously monitoring the P0.1 and delta POC.
Using drugs to lower the objective mathematical drive.
And propofol is incredibly effective at blunting the central drive, reducing the amplitude without abolishing it. Fentanyl drops the respiratory rate and helps mitigate the panic of dyspnea.
Okay, what about patients on ultimate life support? Step 4 addresses VV ECMO.
If they're on ECMO, you maximize the sweep gas flow.
Sweep clears CO2 from the blood, and CO2 is the main stimulus for the brainstem.
Right. By turning up the sweep, you rapidly clear CO2, tricking the brain into thinking the respiratory system is hyperventilating. The brain drastically downregulates the neural drive, quieting the diaphragm.
Okay, but let's look at the worst-case scenario. Optimized PEEP, titrated propofol to objective effort, maxed out ECMO sweep, and their delta POC is still negative 22. They're refractory to everything, destroying their lungs and diaphragm.
This brings us to step 5, the most controversial but mechanically brilliant intervention, partial neuromuscular blockade, or PNMBA.
Which rewrites how we use paralytics. Traditionally, we use a continuous infusion of cisatracurium or rocuronium for total 100% receptor blockade. Turn the diaphragm into paralyzed meat.
But total paralysis guarantees rapid VIDD. It solves the lung problem but creates a catastrophic muscle problem.
So Dianti used partial blockade. Incredibly small, intermittent microboluses of cisatracurium.
Yes. The median dose in the trial was just 2.5 milligrams, sometimes even smaller, 0.5 to 1 milligram. The goal is not paralysis. The goal is just to weaken the muscle's contractile strength.
I think of it like a sports car engine. The central drive is the accelerator jammed to the floor. The engine is redlining, going to blow the pistons. Total paralysis is turning the key and shutting the engine off. But partial blockade acts exactly like an electronic engine governor.
That's a perfect comparison.
The engine is running, patient is awake enough to initiate breaths, frenetic nerve firing at max. But because you pharmacologically blocked a percentage of the neuromuscular junctions, the muscle simply cannot respond with full force.
It physically cannot redline. You've capped the maximum PTS. The governor limits the RPM. The partial blockade limits the transpulmonary stress.
And the success rate in the trial for these refractory patients?
100% rescue success. They brought every single one safely back into the Goldilocks zone.
Without causing complete diaphragmatic silence. So they avoided rapid VIDD. And because they're still breathing spontaneously, they avoided the dangerous respiratory acidosis from abrupt paralysis. It's an elegant physiological hack.
The ultimate synthesis of lung and diaphragm protective ventilation, calibrating the muscle's mechanical output to match the lung's fragility.
We have covered so much dense physiology today. Let's synthesize exactly how this transforms daily practice for the clinician at the bedside. We started by recognizing asynchronies are active biological trauma. Blanch, Vaporidi, Sousa showed us clusters cause structural tearing and cytokine release.
And we established the necessity of the Goldilocks zone, Gall-Layer's framework demanding we balance PSILI on the right with VIDD on the left.
We proved you don't need a balloon. You can use P0.1 for the brainstem's drive, expiratory holds for delta POC, subtracting the chest wall stiffness tax to find true lung stress. And soon, LVU's continuous NPMIS algorithms will handle the math automatically.
And finally, the Dianti protocol to regain control. Early spontaneous breathing, optimizing TEEP for compliance, titrating sedatives to objective metrics, and deploying partial neuromuscular blockade as a precision governor.
So, my direct challenge to you, the listener, on your very next ICU shift, do not just walk past the vent, glance at the tidal volume, and accept they're fine because their RAS is -4. Look closely at the flow waveform. Look for those tiny deflections indicating a fighting diaphragm. Do an expiratory hold. Calculate the stress. Ask yourself, what is this patient's diaphragm doing right now, and is it destroying their lungs?
And as we conclude, I just want to pose a sort of philosophical question about the future of our specialty here. As these NQMIS algorithms become standard, as 2026 and 2027 vents automatically alert us when a patient leaves the Goldilocks zone, how does our role change?
It's a great question.
Will the automation cause us to lose the physical art of assessing patient-ventilator interaction? If the machine gives us the exact PMNS, will we stop looking at their accessory muscles, their diaphoresis?
Or will it free us up?
Exactly. Will outsourcing the computational heavy lifting finally allow us to look away from the screen, step back, and dedicate our full attention to treating the whole complex human being in the bed?
That's the profound tension at the heart of critical care medicine, balancing the algorithm with the physical art of the examination. Thank you for joining PRISM Rounds on this deep dive into the limits of respiratory physiology. Keep questioning the dogmas, master the mechanics, and above all, keep protecting both the lung and the diaphragm. Until next time, keep analyzing the waveforms and don't let those internal gears grind.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.